The open label extension didn't actually begin until the results were known from the core Phase II study. And in fact, it were these results that prompted us to initiate the open label extension to begin with. So this situation afforded us an opportunity to bring consenting subjects back to the open label after having been off lecanemab for an extended period of time, ranging anywhere from 9 months to 59 months, with both mean and median time off of lecanemab at around 24 months or 2 years. In addition to adding to long-term safety and tolerability information, the circumstances around the study in this open label extension offer us a very unique opportunity to answer questions that are both specific to lecanemab and more generally of interest to the AD field as a whole. So objectives related to these questions include, on a general level, understanding what happens after you reduce brain amyloid with an anti-amyloid antibody and then remove treatment. So for instance, does amyloid return? And if so, at what rate does it return? And with respect to lecanemab specifically, we aimed to understand what happens to clinical progression over time after lecanemab treatment is removed. We aim to characterize the time course of amyloid removal by lecanemab. Now keep in mind that in the core study, we only looked at 12 and 18 months of treatment with respect to amyloid PET. And the open label extension includes earlier time points of 3 and 6 months in addition to that 12-month assessment. We also aimed to assess the incidence of ARIA-E in the open label extension with 10 mg per kg biweekly and to compare that incidence to the observed effects to what was seen in the core study. And finally, we aim to understand whether we can challenge ARIA-E by dosing through under some circumstances. So since in the core study, all subjects were immediately discontinued from lecanemab treatment per protocol, regardless of clinical symptoms or radiographic severity, we were unable to assess this particular aspect of ARIA-E. There have been a number of several interesting findings from the open label extension to date. For instance, it was demonstrated in the AAN presentation that the effects of lecanemab on brain amyloid reduction persist for up to 2 years after discontinuation of treatment. The magnitude of effect of lecanemab on brain amyloid in the open label was dependent on core treatment assignment and the associated brain amyloid levels at open label baseline. And that is to say, the magnitude of the effects that we saw were greater in subjects with higher baselines, which are those subjects essentially who were on placebo in the core. And the magnitude of effects were less in subjects who were treated with lecanemab in the core study. This is presumably because the window to observe these treatment effects with respect to PET is reduced when subjects are already starting at lower amyloid levels. Lecanemab rapidly reduced brain amyloid in core placebo-treated subjects. Amyloid reduction was evident in as early as 3 months, and that reduction continued in linear fashion over the 12-month treatment period that we presented. Now, from a safety perspective, incidence of ARIA-E cases in the open label extension with the top dose of 10 mg per kg biweekly was consistent with the incidence observed at 10 mg per kg biweekly in the core. And very importantly, we learned that in the open label extension, we can dose through some cases of asymptomatic, mild or moderate radiologic ARIA-E. So currently there are no approved disease-modifying therapies for patients with early Alzheimer's disease, and as such, introduction of a novel potential disease-modifying therapy would represent a significant shift in the AD field. The findings from this presentation on the study 201 open label extension demonstrate that 10 mg per kg biweekly of lecanemab, the dose being studied in the Phase III Clarity AD study, can be initiated at treatment onset without titration to elicit rapid and robust reduction in brain amyloid with relatively low incidence of ARIA-E. In addition, we've previously presented data indicating that those subjects who returned to the open label extension do start to decline clinically once lecanemab is removed. However, the subjects who were on 10 mg per kg biweekly in the core progressed at a similar rate to those subjects who were on placebo in the core during the time in which they were off of lecanemab, or that is to say the time between the end of the core treatment period and the open label extension baseline. And these findings then suggest potential disease-modifying effects based on the clinical data. The fact that clinical decline continues once lecanemab is removed, even when amyloid levels are negative on average, suggests that we may need to continue treating these subjects even after amyloid is removed. And finally, these data also suggest a potential role for the soluble amyloid aggregate species or protofibrils in contributing to clinical decline. That said, further work, of course, is on assessing the clinical meaningfulness of these data remains ongoing in Clarity AD and in the Study 201 open label extension.